I'm good, thank you. Hello, everyone. I'm just waiting a little bit for more people to come. I see we have a few people that just joined us. How exciting. My name is Rachel. For those of you who don't know, it's very nice to meet everybody. I'm just gonna get my PowerPoint set up.
Can you hear me?
Yes, so I'm very excited to see everybody. Hello. Can you all see the PowerPoint? I have the Childbirth Masterclass PowerPoint, and you guys can also access it. I think probably all of you guys signed up for Eventbrite from the website. If not, you can always email me as well. My email is mommydidyouknow@gmail.com.
Can people mute their phones?
Yeah, it would be best if you guys can mute your microphones. And then there's a chat box. I'm going to say something here. So the chat box is what we will be using to communicate during this class. It is good stays connected, especially because I like to use this as a Q&A, so that everybody can be able to be interactive, ask questions. I know that as we're pregnant, there's probably a lot of questions that pop up. So I'm going to start off. I am from Florida. So if you guys can just say your name, where you're from, and maybe how many weeks pregnant you are. Usually I find most people in this class are in their second or third trimester, but it's good to get a handle of where everybody's at. So I'll give you some time to do that. You just write it in the chat box with the Zoom. And I will be doing a free consultation in the end of this class as well. So hi, Marty. It's very nice to meet you. Oh, you're a student nurse. That's fantastic. Actually, I love nursing. For those of you who are also a full-time nurse, so I work in maternity. I also work in nursery, a little bit of NICU. So it's a little bit of everything, and I absolutely love what I do. Virginia, 33 weeks. Perfect. So what I love about this class, especially because I find that a lot of the hospitals have canceled their classes. So at least this is a way that you can kind of talk to a nurse kind of one-on-one. I'm a lactation nurse, so I'm actually a certified lactation counselor as well as a full-time nurse. So it's a great resource to be able to have. And then you can also download this PowerPoint from the Eventbrite page that you signed up on. If you didn't sign up on Eventbrite or you're not if you don't know where to find it, you can even just email me and I can email it to you as well. So to start off, there's 4 topics that we like to talk about in this class. There's pregnancy, childbirth, postpartum care, as well as newborn care. I find that a lot of people, they really dive into childbirth and then they kind of neglect themselves as a mom. And it's kind of difficult to take care of your baby if you're not taking care of yourself. So I really love to spend some time about postpartum, what to do after you deliver, how to take care of yourself after your childbirth. And that's really important. And then, of course, newborn care. This is a 1-hour class. As much as I would love to tell you everything and put everything that's in my brain into your minds, unfortunately, that would be very difficult in only a 1-hour session. So I also do have personal consultations that's a one-on-one that we can schedule for 30 minutes, 1 hour, an hour and a half, whatever you guys need as well. And then that can be more personalized for what you need. And to schedule that, you can always email me for more information, mommydidyouknow@gmail.com. So to start off with pregnancy, as you know, there's a lot of changes that happens to your body. Most of you guys are in your second or rather late in your pregnancy towards the third trimester. So I'm not going to go too much into this, but I want to know what you guys are dealing with in your pregnancy so that I might be able to help you individually. I know that for me, I dealt a lot with nausea in my first pregnancy. What I would have to do is actually suck on lemons in order to help with my nausea. But water really helps with nausea, staying away from greasy foods as well. And I know that there's plenty of things that you guys are dealing with. I also had sciatica. Sciatica, basically, it feels like lightning coming from your pelvic area all the way down your body. So I dealt with that a lot as well. Those are just some common things that you might deal with in pregnancy. With sciatica, what really helps is a binder, a support band. If you have a support band, that really, really helps kind of just keep everything in place and keep the pressure where it needs to be so you don't get that really bad pain. I also sometimes even used a pillow in between the legs, and that helped as well. So for sciatica, and then of course we have some nausea. Does anybody else have anything that they're dealing with during their pregnancy that we might be able to go through? I have some lists of different things here in my PowerPoint. Nasal congestion. For me, I had some nasal congestion as well, especially in my second trimester, going to my third with both pregnancies. Just make sure that you're not using Afrin sprays, because Afrin sprays can actually mess with your heart, along with a few other different things as well. But the saline drops, they work very, very well. Groin pain, ligament pressure. So you are exactly where I am, Marcy. Well, I was during my pregnancies, that I remember I would be a nurse checking your fundus. So after you have your baby, as a nurse, we will be checking your uterus, the position of the uterus, and we call it a fundus. So I would be bending down, checking people's, bleeding, how's the lochia doing, how's the fundus doing, and then all of a sudden I would get sharp pains that went from my pelvic region, went all the way down. So I'm with you there. What really helped me was support bands and kind of also paying attention to my movements, because I noticed if I would bend a certain way that I would get that sharp pain again. Support bands still didn't help. Sometimes actually the doctor might even send you for therapy, for physical therapy. I noticed that for people that really, hopefully it gets better soon. How many weeks pregnant are you, Marcy? I forgot if you mentioned it. Oh, 29, you're due in 29 days. Okay, so you're almost towards the end there. So as the baby gets bigger, of course, there's more that the baby's going to be pushing. I really, really hope you do get better. That sometimes they say that acupuncture helps. Sometimes therapy has been helping. Different things. Hopefully pretty soon. I'm so sorry you have to go through that, because from one mom who had to deal from it to another, I know it's hard. Oh, and actually what really helped too were actually the soles of my feet for my shoes, because what I noticed is actually if my shoes and my feet position were off, it even was kind of affecting the position of my pelvic bones. So yeah, so actually maybe we're right on the money there, on the point, with maybe something that might help, as well as maybe getting more supportive soles of your feet. And then I know someone else said that they're having pregnancy-induced carpal tunnel. So they actually have these wrist bands that you can buy. I would recommend buying them on Amazon rather than getting the private ones, just because they're usually a lot cheaper. And you want to save money as a new parent. So they do have those support wristbands. They also have kind of heat, icy hot. And if you have some people, they have a job like mine where you're kind of typing a lot or you're on the computer a lot. They even have these pillows that you can put underneath the wrist, which can really help, because sometimes that happens for people that are either using their phone a lot for work, or you're on the computer a lot for work. So sometimes that does end up making a big difference. And I really hope that does help. So we went over nasal congestion, we went over nausea, sciatica. And if you guys have anything else that you're dealing with, I know heartburn, for example, is a big one. Stay away from greasy foods, drink a lot of water, and then also try not to eat before going to sleep. That also really, really helps. And sleeping fun times, yes, insomnia is very common during your pregnancy as well, especially as you're, uncomfortable. Your baby is against your bladder, your baby is against your stomach, your baby is against your lungs. You can barely breathe and kicking you as soon as you finally fall asleep. So what helps for that for me is I'll try to have a nice tea before bed, try to limit your screen time. I know, like, for me, my weakness is my phone, like I'm about to go to sleep and I'm like, oh, I wonder what just happened, or did someone email me, especially as somebody who gives consultations, I'm always checking to see if someone has texted me or if they have a question. But sometimes you also have to think of yourself. You have to think of your health. And if I'm up until 1 o'clock in the morning answering emails, I probably will not have the most beneficial sleep that will help me or whoever I'm trying to talk to. So those are just different things to think about. And then our next slide is some important milestones for your baby. I know everybody loves to talk about how their baby is developing, and you guys probably have those apps. My baby is the size of an apricot, or all of those different things. So my question for you guys, and this is for anybody who's on the Zoom meeting, because I'm monitoring the chat from the Zoom meeting, is at how many weeks, and you can look at the PowerPoint, at how many weeks is your baby considered early term? So at how many weeks is your baby considered about cooked? There's something that's called fully term, and then there's something called early term. And you can look at the PowerPoint. How many weeks is your baby considered early term? Exactly, 37 weeks. So the difference is at 37 weeks, usually your baby is considered all right, although they normally will not schedule you for an induction or an elective cesarean until your baby is fully term, which is 39 weeks. So there's a difference between early term and fully term. Full term at 39 weeks is when you'll probably be scheduled if you are up for an induction, whether it be for maternal reasons, baby reasons, or an elective cesarean. It's normally about 39 weeks. If you have any issues in your pregnancy, you have high blood pressure, you have extremely bad problems with your blood sugar, sometimes even IUGR, intrauterine growth restriction, sometimes they'll even induce you or deliver you before that when the baby is early term at 37 weeks. So basically 37 weeks, you'll be delivering then. If you have any complications during your pregnancy, they'll sometimes deliver you a little bit earlier, but we're considered fully cooked at 39 weeks. That is when, if your baby is delivering around 39 weeks, your baby is very good. If your baby is between 35 weeks and 37 weeks, most hospitals would be looking at your baby a lot. And as long as your baby is breathing, and as long as your baby is eating okay, your baby should be able to stay with you. Now, the biggest thing, of course, that all determines by risk factors and everything like that. But normally, anything before 35 weeks, so let's say you are pregnant and before 35 weeks, you end up in labor and you end up having your baby. Anything before 35 weeks is an automatic ticket to the NICU. That's most hospitals, no matter where you are, that's normally what they do. If you are between 35 and 37 weeks, your baby will probably have a little bit more lab work that they'll do and different exams. But as long as your baby's breathing okay and eating okay, and the baby doesn't have any signs of infection or any complications with jaundice, which can sometimes affect babies that are premature, your baby should be able to stay with you. Between 37 weeks and, of course, fully term, that's when usually the babies do a lot better. But if your baby's born, a little bit too early, sometimes we just have to look out to make sure that they are eating well and that they are breathing well. So who can tell me, and I want you guys to be active in the chat because that's how I know that you guys are listening and that you guys are paying attention. So who can tell me some signs of respiratory distress? Now, this is very, very important for all parents to know and your caregivers. So how would you know, especially let's say you have a premature baby, how would you know that your baby is breathing off, that your baby's not breathing that well? So Marcy had it with the turning blue, but let's see if anybody else can tell me, how would you tell that your baby is not breathing very well? Besides the turning blue, because yes, exactly. So Miss Scott definitely has it. I don't know if Nobi, but nasal flaring. That is actually when your nose starts actually going, and you'll actually start seeing the nose flare up. That is a sign of respiratory distress. So if your baby starts showing those signs, that is a sign that your baby definitely, you might want to take a look to see how your baby's breathing. Kristen also said retractions. Retractions are basically when your baby is using accessory muscles to breathe. So normally we're breathing, your baby, you might see the belly go up and down, but if you see those ribs kind of going in and out and those accessory muscles go in and out, that is a sign that your baby is not breathing well. So these are all very, very important signs. The blue, the nasal flaring, the retractions. Another thing that I want to talk about is called tachypnea, which is also called, tachypnea basically is when your baby is breathing fast. Keep in mind that there is something kind of interesting with babies when it comes to their respirations, because one, a baby's respirations are not regular like an adult. Like for me, for example, you look at my respirations, it's pretty regular unless we're doing a marathon or something, but it goes up, down in a pretty regular fashion. Babies, they'll tend to have little bursts of breaths. So they'll have 1, 2, 3, and then they'll have a little apneic episode for a few seconds, not too long. They go like 1, 2, 3, and then they'll stop for a sec. 1, 2. So their breathing is not necessarily regular, they're irregular breathing. So especially for newborns, if you truly want to get a grasp of how many breaths per minute your baby is doing, and that also goes for, I know we said somebody was going through nursing school today. Who was it? Oh, Nobi. So that's probably how you knew the term nasal flaring. But that is very important for nurses, new nurses, parents to know that when you're checking your baby's breathing, you'll check for that chest rise, or you'll see that baby's rising over 1 full minute. Because if you are just checking for 10 seconds, it's very likely that you might have just a few bursts of breaths, and then you might not get a very accurate picture. And then you'll say, why is my baby not breathing that fast? Or why is my baby breathing so fast? So it all depends on the baby. And then next is your baby's breathing rate. So actually breaths per minute is very different than an adult. For an adult, it's very common, let's say 16, 18 breaths per minute, even less, sometimes more. But with babies, it's actually about 30 to 60 breaths per minute. So you'll notice that they will be breathing faster. So I actually get this a lot from parents is I'll hear them say, what's going on? My baby is breathing so fast. What is going on here? But it really is that it's normal for babies to breathe between 30 to 60 times per minute. If they're breathing way too fast, over 60, that's called tachypnea. That's breathing way too fast. And then that's when I start to look and I'm saying, hey, what's going on? Sometimes it's something as simple as the babies just ate. Sometimes after babies eat, sometimes they're working hard and then they're breathing because, it's hard to eat and breathe and digest. So those are all different things to think about. So I know all of you guys pretty much are in your second, third trimester. And I have over here your typical prenatal schedule, which of course, these are guidelines. So not everybody follows them exactly, and not all the doctors will follow them exactly as well. But it's good to kind of have a basis of what to expect. But one thing that's very important for everybody is make sure that you're keeping up with your prenatal visits. I know that right now, as COVID is happening and there's so many questions going on, And a lot of the doctors are not doing in-person visits except for certain times. I've noticed some people kind of stagger, like they'll have one in-person and one virtual visit, one in-person, one virtual. But whatever you do, make sure that you're keeping up with those, just because it's good to have someone to talk to ask questions, and keep up with your not only prenatal visits for OB visits, but I also do consultations as well. So for prenatal education is important as well, if you think about it, because your prenatal education really gets you ready and it tells you what to expect. And a lot of times our consultations will answer a lot more questions than you can when you go for your OB visit, just because the nature of a consultation is more of a Q&A that we can talk to you directly. So for your typical schedule, usually initially you'll have some prenatal labs, which will have your blood type, you'll have your type and screen. The donor, the universal donor, by the way, is O positive. Well, O is the universal donor. I'm O positive. So if you are blood type O, it's the most common, and you're also the universal donor. AB is the universal receiver. So AB is actually the least common, but it is also the universal receiver. So nature has this way of balancing out. The most common blood type is the universal donor, and the least common blood type is actually the universal receiver. So even though there might not be that much AB blood types out there, you can receive pretty much almost all blood types. It just depends on the RH and a few other different things. Other prenatal history, we're also looking at your HIV results, your rubella, HSV. You can also contact me if you want to know what to expect. If you have a positive, let's say you're positive GBS, positive HSV, positive HIV, hepatitis B, I can always talk to you about what to expect as well, just because there's certain extra tests to do for you or the baby. And if you guys have any questions during this class, you can also leave a message as well and just comment, and then I would love to answer it for you. So around weeks 11 to 18, and then of course this is a guideline, they normally do the nuchal translucency or the quad screen, which is genetic testing. Basically the nuchal translucency, it sees if there is in that neck area, that neck space, if there is kind of liquid material there. Sometimes that can be a sign of genetic abnormalities, sometimes like Down syndrome. But just because the baby does have that does not necessarily mean that it will be born with Down syndrome. It's just a higher likelihood, a higher chance. Same thing with the quad screen. I've had people have a positive quad screen and the baby comes out perfectly normal. So those are just signs that if you are positive for any of those tests, of those genetic tests, that the baby is higher likelihood of having genetic abnormalities, but that does not mean that it's 100% accurate. So keep that in mind, and you can also go to genetic counseling, and they have other tests as well that you can follow up with that. Next, around 18 to 22 weeks, they do the fetal anatomy ultrasound, which is, of course, everybody's favorite one, because that's when they start talking about the baby and the anatomy of the baby, and everybody loves to talk about if it's a boy or a girl. Sometimes it can come back with a little abnormality in the ultrasound, like a spot. Did anybody in our class have anything abnormal come back in the ultrasound? I know that sometimes they might have something called an echocardiogenic focus, or sometimes even they might have a spot in the kidneys. That does not necessarily mean that something's wrong. It's just if there is a spot in that ultrasound, that sometimes they might have to do extra tests, such as EKG, echocardiogram as well once the baby is born, and they might have to see a cardiologist. That's if the spot is in the heart. And then, of course, after that, we start getting a glucose screening, and towards the end of your pregnancy, GBS. Do we have anybody that, or if you want to say if anybody is GBS positive, so keep that in mind. GBS is a natural occurring bacteria that a lot of women have. It's a group beta strep. It's natural and a lot of women have it, but strep B, exactly, Marcy. So strep B, group beta strep, getting tested tomorrow. So that the way they test it is actually a swab. So they'll do that in the vaginal area, they'll swab, and it normally takes a few days to sometimes even a few weeks, honestly. It really depends on the doctor, but hopefully when you get those results back, they're negative. But if they are positive, which is very, very common, one, you'll probably have to have antibiotics before you have your baby. So when you're in glucose test safe, that really depends on, like, when you say like if it's an obligation to have, it is highly, highly recommended to have the glucose tolerance test. The reason is because if your sugar levels are too high for long periods of time, it can be very detrimental for you and the baby. If you think about it this way, high levels of sugar in the body is kind of like shards of glass that just destroy everything in its path. So that's why when sugar is so high, like sometimes you might have somebody that's even like 500, 600, and it gets so high like that, it can actually be detrimental to the baby, detrimental to mom. And also babies, they have problems when they're in the uterus. If that blood sugar is too high, they can actually be bigger for gestational age, large for gestational age. And then also when the baby's out, sometimes they even have blood sugar issues as well. But normally the glucose test, if it comes back abnormal, most of the time it's treated okay with diet. Sometimes they have to treat it with insulin and pills, but most of the time with diet. And then the swab check, sorry, don't know how to pronounce your name, Mukti, but the swab check, what I was saying, the swab test is for the group beta strep. So that's the other test that I was talking about, the GBS. Group beta strep is a naturally occurring bacteria in the vaginal area. So if somebody were to be positive for that, it's normal for women and adult women to have group beta strep, but if a baby has it, it can be harmful to a baby and it can cause infection, such as when you are delivering your baby. If you have group beta strep in that vaginal area and it affects the baby, it can cause infection for the baby. And sometimes it's even late onset infection as well. So that's why the GBS test is very, very important to check out for you guys, okay? So we have group beta strep. We talked a little bit about the glucose tolerance test. You are very, very welcome. And if you guys have any other questions, let me know. And I did want to talk a little bit more about gestational diabetes and preeclampsia. And that's pretty much our last part about pregnancy before we go a little bit more. And I know that there's a lot of information and sometimes it seems like information overload. I do have online. You are very welcome, everybody. I do have online a childbirth masterclass online that the link is actually on the Eventbrite page and it's also on mommydidyouknow.com. And then that's actually 1 month. I just couldn't stop myself from writing all this information. So I have videos, I have articles, and it's literally 1 month long. And it goes over pregnancy, childbirth, newborn care, bottle feeding, breastfeeding, pumping, like everything under the sun. That's the Childbirth Masterclass online. So that actually has all of this, but in way more detail. So if you really, really want to learn more, and not to toot my own horn, but I'm a pretty good teacher and I like to teach and I really enjoy doing this. And there's a lot of information out there. And one thing that's very important is for people to be informed and have the right information from a source that they can trust. So a little bit about gestational diabetes. Gestational diabetes is high blood sugar during pregnancy. What to keep in mind is that just because you have diabetes does not mean that you'll necessarily have diabetes after you have your baby. A lot of the times gestational diabetes goes away on its own once the baby is born and all those hormones and everything gets back to normal. Most of the time it's also regulated by diet, although sometimes you might need pills or injections. Usually the insulin injections are short term and the pills are more long term. So sometimes it's a combination, sometimes it's one or the other. Really depends on you. If your glucose tolerance test comes back abnormal, you're normally seen by a perinatologist who will go over your plan directly with you about, are you going to do diet? Are you going to do exercise? Maybe they'll try that for a little bit and then move on from there. It all depends on you, your plan, what your wishes are as a person. It's very important that you remain an active participant of your healthcare team as well. So make sure that you're not just giving your arm and saying, okay, yeah, take whatever test you need. Make sure that you are an active participant, that you are staying alert, that you're asking questions and trying as hard as you can to really know what's going on. And then some complications, number one, C-section, if your blood sugar gets too crazy too fast, or even you might have to induced early. So those are just different things to think about. Also a high birth weight baby. And then if you have a bigger baby, sometimes that can have complications for vaginal delivery. And sometimes also it can affect the baby's blood sugar maintenance after the baby's out. So those are all things to think about. Hypoglycemic baby as well. So if you think about it, your placenta is giving all of that sugar. Then all of a sudden the baby's out and the baby does not have that same nourishment, same nutrients that was coming from you. So sometimes they deplete those reserves and then they become hypoglycemic and their sugar starts to drop very, very fast. So those are all complications of gestational diabetes. And I know that this is a very, very common condition that a lot of pregnant women have. So I make sure to definitely talk about it in my classes. Do we have questions about gestational diabetes? I know that we have a lot of different things that we've been going over today, but if you have any questions about gestational diabetes, let me know. Next is preeclampsia or high blood pressure. So keep that in mind. Preeclampsia is very important to know about, especially because a lot of people might have it and not even realize it until the symptoms start to arise. And many times the symptoms come too late, because normally symptoms start when your blood pressure has all of a sudden skyrocketed. So different symptoms of high blood pressure: blurred vision, headaches, stomach pains, swelling, all of those are definitely signs of high blood pressure. Dizziness too, sometimes a lot of them are kind of in your head of what you would think about. But one way to kind of prevent it from getting to that area is try to be on top of your prenatal visit. So the more you're on top of your prenatal visits, the better your chances of catching that preeclampsia before it gets to that level. And then treatments, early delivery. So sometimes you might even need to deliver before that 39 weeks, because remember we said normally your inductions and C-sections are around 39 weeks. Well, what happens with preeclampsia is sometimes you might have to deliver earlier if the severity calls for it. So if it's mild preeclampsia, it might even be 37 weeks to 38, going from there. If it's very, very bad, they might even have to deliver you earlier. And then treatments are medications before you deliver, as well as sometimes there's medications after you deliver. And keep in mind as well that you can still have increased blood pressure after you deliver, which is a very big thing that I don't think a lot of women know about, but that's actually a very big condition that a lot of women don't realize. Is if you're thinking about it, after you deliver, all of that fluid is leaving your belly, and all that fluid, all that amniotic fluid that was there and all that extra circulation, it is going all around your body. Plus, not to mention, there's normal vessel changes that are happening after you have your baby. It's a lot of changes going on. So sometimes what happens is your blood pressure levels can go up very, very fast. So keep in mind, after you deliver, even if you did not have any problems with blood pressure during your pregnancy, keep in mind about that. And then Marcy wants to know, how long do you have to worry about it? They have me on baby aspirin to help prevent it. Unfortunately, it is something that you would want to think about even after a few weeks postpartum, just because you never know when blood pressure levels can rise. And as a postpartum nurse, I have seen it happen quite often where somebody that never even had problems during their pregnancy, they all of a sudden start spiking their blood pressure after they delivered. It actually happened to me once where we actually were discharging somebody. It's probably 3 days after she delivered. She had a cesarean birth. Everything was perfectly fine. Everything was fine with her blood pressure. And then all of a sudden we take her discharge vital signs and her blood pressure was all the way up, like 160s over 110s. And then it just started going up, 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 up. And she ended up being in the hospital for a few more days after that, having to get IV blood pressure medications until it stabilized. So that late onset blood pressure issues can still happen. So just keep that in mind. If you have blurred vision, headaches, you're having the swelling, make sure that you're also keeping in charge of your vital signs. If you have high blood pressure during your pregnancy, don't be lazy with it. I know that a lot of times you have a lot of things that you're thinking about, and taking your blood pressure doesn't really seem that it's on the top of your list. But make sure if you have blood pressure issues, especially if you're taking medications for your blood pressure, try to take your blood pressure before you take your medications. Keep on top of that. You know, whatever, if they are recommending you take your blood pressure every 4 hours, or every 8 hours, or, you know, twice a day while you're awake, just keep that in mind, you know, to keep that in, that is so important. So we just went over pregnancy, and I want to go over childbirth. And I know that this is a very important part that a lot of people want to know about. Does anybody have any questions about pregnancy before we just go over a little bit about childbirth? Sorry, guys. A little bit of a cough. And then I have 2 toddlers, so I'm ending up using their cups. I end up having more toddler cups and plates and everything than I do adult. Everything ends up revolving around your kids in the end. So we have childbirth and delivery. I just want to start off with some signs of labor. So for the chat, this is a question for you guys. What is the difference between true labor and false labor? How can you tell the difference? So let's say you are contracting and you are at home. How would you know if this is true labor, and how would you know if this is false labor? So I want all of you guys to stay active. You can comment on the chat so I can see what you guys know. And then there are a few different ways that you can tell. True labor is very consistent, it's regular, and it doesn't really go away when you are resting or drink fluids. False labor, on the other hand, is usually very irregular, and it normally goes away when you start resting and drink fluids. So if you are timing your contractions and you're saying, okay, it's every 10 minutes, it's every 7 minutes, those are because they're regular, it's probably true. And then another thing is usually, usually also true labor, you can't really breathe and talk through them. I remember with my first, I didn't really go into natural labor. I had to be induced. With my second, I remember going into labor and I knew it was true because I wasn't able to talk through it. Although I was trying to be calm, I'm the type of person that's still gonna walk in with a smile. So I'm like, okay, I'm here to have my baby. But I couldn't really talk that much. I couldn't really breathe that much as I tried. So those are the difference between true and false. True is regular, it's consistent, you can't breathe through it. Or you can breathe through it, but it's a little bit harder. False labor is irregular. You normally, if you drink some fluids and rest, normally goes away. That's the difference. And false labor is also sometimes Braxton Hicks, but Braxton Hicks, I also like to say, rather than false labor, is practice contractions, because Braxton Hicks is basically your body getting ready for delivery. So that does not necessarily mean that it's like false labor. I kind of like to say it's practice contractions. It's just your body getting ready for delivery. So sometimes it can even happen during your, let's say 36 weeks, and you start getting Braxton Hicks, sometimes even earlier. It all depends on you. Then some other signs: lightning, bloody show, nesting instinct, water breaking. Although keep in mind, your water does not have to break for you to be in labor. I think some people, they get a little confused about that, but your water does not have to break for you to be in labor. Then there's regular and intense contractions. That's also another sign of true labor. Next, I'm just going to briefly go over your hospital bag checklist. I do have an article on mommydidyouknow.com. That's the hospital bag checklist. It's very, very good. It goes over everything that you need, some things that you don't need. I think simpler the better. For mom, just think comfort. You want to bring comfy shoes, comfy slippers, comfy robe. Get out of the hospital gown. You don't want to wear the hospital gown forever. You want to be able to feel like yourself, feel like you can take care of yourself, feel like you can take care of your baby. For the baby, you don't need to bring much. Honestly, the hospital gives you wipes. Usually they'll give you diapers. They even have shirts. I would, though, bring your own baby clothes, just because normally the hospital shirts honestly are not that great. They're either kind of paper, or they might just be a shirt and no pants. Or sometimes if I have a patient that doesn't have any clothes, I might have the shirt and I'll make pants out of the shirt. But sometimes it's better to have your own clothes, unless, I mean, it's good to do skin to skin as well. But, you know, if you want your own clothes, that's good. You will need a car seat installed in your car. Most hospitals, just keep in mind, do not install the car seat for you. You normally will have to, the best bet if you want your car seat installed is to contact your local fire department, and they normally can be able to point you in the right direction. Some fire departments have specific times that you make appointments and they can install your car seat, but hospital staff usually cannot install your car seat unless they're super, super nice and they like you a lot. But even so, it's not their professional responsibility to, because of course there's also liability involved with that car seat. So you want to make sure that it is installed and ready to go. What I have seen some people do, which is actually pretty cool, is I've seen some people bring the actual car seat in to the hospital inside the room, strap the baby to adjust the straps, and bring that car seat back out. That way it's already adjusted for the baby when you're leaving, so that you're not sitting outside of the hospital and trying to adjust all the straps, you know? So I have seen some people do that. Some other things that you might not think about is number one is prenatal records. That's another great thing to put in your hospital bag, just because if we don't have your records as hospital staff, sometimes we have to do extra tests, because as a hospital, especially when we're dealing with babies, we are considered positive until proven negative, because whenever you are dealing with a baby, you want to be safe. And you had a question. And then if anybody else has a question, you can always let me know. But prenatal records is very, very important for you to bring to the hospital. Another thing is, if the hospital is linked to the same, if the same hospital is connected to your medical group, they should be able to look it up. However, sometimes I've seen them not be able to pull it up, whether it be a technical issue or the system is down. And for me, I would rather not mess with it and just have it just in case. And I know that even a lot of doctors have access to it on your mobile phone. Just even me as a nurse, if let's say we can't get the records from the doctor's office, but you have your electronic medical records and we know that your office will be sending the records soon, I can at least look at those electronic records in the meantime. Because what happens is, if we don't have any records and we're treating you like fresh from scratch, we end up having to do all of your prenatal labs, the HIV, the hepatitis B, all of that stuff. We might even have to re-swab you for GBS, chlamydia, gonorrhea. They will have a lot more. And then plus, sometimes your OB's notes have more information than we might know just from talking to you. Like sometimes they'll have very important information about the genetic screening that maybe you might not know all of the details. Or sometimes as a patient, they'll say, oh yeah, something was off with my anatomy ultrasound, but we don't have the anatomy ultrasound. So then we'll have to redo more tests. So for me, I usually with my kids, both of them, even though the hospital was linked to the group, I still had my records with me when I reached 36 weeks, just to make sure that everything was there, because I don't want to have extra labs for me. I hate needles. Nurses are the worst with needles. And two is I don't want extra tests for my baby. Because that's another thing, is you're not the only one being tested for these, but if we don't know your results, we don't know the baby's either. So sometimes the baby will even have to have extra tests as well. So I like even having access to the records kind of helps save you and save the baby from unnecessary treatments. Then we have some tidbits here about vaginal exams. So I know a lot of times, as I know how it is, you're getting close to the baby delivering, you're like, all right, check me, how open am I? How open is the cervix? And that's pretty much all you really know about what the doctor's looking for in terms of vaginal exams. So I just wanted to break down what are the different parts of a vaginal exam and what are they looking for. So number one is the dilation, which everybody knows is how wide or open is the cervix. You know, we normally are getting it, it's, you know, closed or 10, it's like, it's open, that baby's ready to come. And next is the, is the ripeness, is the cervix soft? If your cervix is not soft, and then they might have to have a cervical ripener, such as Cervidil, in order, if you were to be induced and your cervix was not soft, then sometimes they might need a cervical softener first, or ripener, in order to soften the cervix and hopefully start to get it dilated, because it's not going to start dilating if it's not soft. The other is effacement. It's how thin. Usually this is a percentage from 0 to 100. So if we're saying, okay, you are 5 centimeters dilated and you are 100% effaced and the cervix is nice and soft, then we're saying that you are in active labor and the baby's probably coming rather soon, because your cervix is thin, it's soft, and you're starting to dilate. So those are all good signs. The next is the station of the baby. So if your doctor is checking you and they say, okay, the baby is at +1 station, that is saying the baby is actually past the pelvis. So if your baby is engaged in the pelvis, that is at 0. So pelvic engagement is at 0. If the baby is past the pelvis already, that's in +1, +2, the baby's coming fast. Negatives is just the baby still has not engaged in the pelvis. So if you're being checked, you say, okay, the baby is at +2 station. That means that you're getting ready to push. That's good. The baby's coming. Then, of course, they're looking for the position of the baby. Is the baby coming head first? Is the baby coming feet first? You know, hopefully not feet first, hopefully not butt first. Hopefully the baby is coming head first. But all of those are very important to know. And then if the baby is not positioned correctly for birth, sometimes they might have to manually move the baby. Hopefully the baby can move manually. If not, you might have to be up for a cesarean. And then do the cervical checks starting tomorrow. Hurt. I'm going to be honest, it is not comfortable to have your cervix checked. Sometimes they might even do different things to kind of get labor started. They are not very comfortable, just to keep that in mind. But to help with the cervical checks, number one is make sure that you have a nice position, that you are relaxed, and that you are open enough, that you're relaxed, that you're breathing, and that you're not too tense, because the more tense you are, the more uncomfortable these cervical checks are. Cervical checks are not like a pap smear. You know, when you have your pap smear and they put the thing inside, they open it up, and then they start swabbing around. Those are more for cervical exam, like cervical tests, the swabs. If it's just a cervical exam, it is done with normally just a sterile gloved hand. So that's to think about as well. Then we have different stages of labor. So stage 1 is early labor to full dilation. So that's your labor part, your contraction part is your cervical dilation. That's all happening in stage 1. Stage 2 is pushing. Stage 3 is the delivery of the placenta. So keep in mind, once the baby's out, the placenta still has to come out. And if it does not come out completely, sometimes that can be indication for manual extraction of the placenta, which hopefully you won't have to do. And then stage 4 is the golden hour. So who can tell me some things that you definitely want to happen in the golden hour? So the first hour of life is called the golden hour. Exactly, good, thank you. So the golden hour is when you want skin to skin. That's the time where you want your skin to skin. That's the time where you want to initiate breastfeeding. That really helps to initiate the relationship with you and your baby. The golden hour, there's also a lot going on in terms of transitioning for your baby, transitioning for you. So actually having the baby skin to skin releases all these special hormones that help you and your baby to transition to life outside of the uterus. And then tips to progress your labor. Now, a really important one is keep calm. Stress will prolong your labor. So try to keep calm, manage your breathing. Another really important note is that breathing is not only for pain management, breathing is also for your baby, because what happens during your contractions, if you're thinking about it, let's say your placenta's here and your baby's here receiving all the nutrients from the placenta. Every time you are contracting, you are kind of inhibiting the oxygen coming between your placenta and your baby. Therefore, sometimes your baby's oxygen levels, the baby's heart rate goes down a little bit. If you are not breathing effectively during your labor, and especially during those contractions, the oxygen level for the baby can decrease. That's why one thing that a lot of people don't realize is that breathing really helps naturally to keep that baby of yours healthy. That's why if you are not breathing effectively or your oxygen levels are decreasing, they're going to try everything possible to help you and your baby. So if your baby's heart rate starts dropping, for example, they'll try to turn you on your side, normally your left side first. If that doesn't work, they might flip you over, go to your right side. They'll try to put on some oxygen for you. The oxygen, even though it's for you, it's actually for the baby. And then so you mean if you have to have a catheter, if you get an epidural, yes, okay. If you are getting an epidural, usually you would have to have a catheter unless it is a walking epidural. The reason is because epidurals, they're complete nerve block from down below, from the pelvis and down, and you want to keep that bladder empty. So if you are having an epidural and you can't walk, you can't go to the bathroom, normally you will have to. So another thing to realize, okay, you're saying, how is there room with the baby coming out the same area? Well, two things. One is that the catheter does not go into the vagina. The catheter goes into the urethra, because your urethra, there's actually two holes in the female anatomy. The urethra is what the pee comes out of, and then the vaginal area is what the baby will be coming out of. So the catheter is actually coming out of a completely different hole than the vagina. Yeah, I know. It's a very common misconception. And two is actually, usually they take out the catheter before. No, it's completely fine as a question. And it's a very good question too, because I get that a lot. It's like, how is there room for everything? But actually they do take out the catheter before. Usually they'll take out the catheter before you have the baby. The catheter, more than anything, is to keep the bladder empty. And then exactly, I mean, there's not that many classes right now. That's why I really, really enjoy doing these. And like I said, I mean, there's so much more information that I want to talk to you guys about. And of course, everybody has different questions. So you can also email me here. Let me put in my email at gmail.com. And I will be emailing the people that are signed up for the Eventbrite class, because I have all of your emails. So I'll be able to send you guys information, because I know that classes are canceled and it's hard right now to find resources and information that you need in education. So when you are pushing, so someone says, does it feel like you're pooping? It actually does kind of feel like you're pooping. The reason is because of all the pressure. So as the baby is putting the stress on your body, sometimes it does feel like the pressure of pooping. However, it's very important not to push until your doctor says you're ready. The reason is because if you push in the wrong time, that's how you can tear more. So, and some doctors even, they'll massage with different oils and things like that to kind of soften the area as well. And then I have more information as well on my website, mommydidyouknow.com. Do you push like you have a bowel movement? Well, you're using similar muscles. I would say you're using similar muscles, but more than anything, it's natural, it's common. And what I'm going to do is everybody who is on the Eventbrite page, if you are signed up, what I'm going to do is send you some links. I'm going to send you a link to the what to expect in cesarean delivery, what to expect in a vaginal delivery, and then that way it'll help to answer some questions as well, because I know that there are a lot of questions, and unfortunately there's only so much we can talk about in only 1 hour, but I really hope that this was a good class for you. So we did talk to you about, because we're kind of pressed for time now. There's not that much time left. I wish I had more time with you because you guys are such a fun group of people. But so for my end of the class, I like to do end of the class consultation giveaway. That's just a good way to hopefully get some resources out to those who need it. So the way that you enter the giveaway is very simple. These are just for the people that are on the Zoom meeting, because that's the chat that I am looking at is the Zoom chat. And what I'm going to do is I'm going to have a review, okay? That's just going to have a few questions. The people that are active in the review and answering the questions are the ones that will be entered for the giveaway for the free consultation. And then everybody else can also email me at mommydidyouknow@gmail.com for consults. You can also do the Childbirth Masterclass online class, which is amazing. So I'm going to start the review. I hope that all of you guys are ready. So number 1, let's see. What are some complications of preeclampsia? That is high blood pressure. So you can say signs of high blood pressure. You can tell me some different complications if your blood pressure gets too high. So at least we can have a nice review. So exactly, so Mary has it. So we have some swelling in the legs. That's a complication of preeclampsia. So high blood pressure, exactly, Novi, very good. So complications of preeclampsia, we have high blood pressure, we have swelling, we can have headaches, blurred vision, all of those different things. Complications also include if your blood pressure gets too high too fast, you can even possibly have to have a cesarean delivery and premature delivery. So those are very, very important to know. Let's say who can tell me about GBS? So you can write that in the comment is, who can tell me about GBS? What is it? Group beta strep. And why is it important to know during your pregnancy? So you can say, what is group beta strep? You can say what you might need to do if you are GBS positive. So the glucose test for sugar levels is actually the glucose tolerance test. The GBS is actually group beta strep. So exactly, so Mary, it's an infection that can be passed vertically to the baby. And Kate, you might need meds before delivery is completely true. So the difference between the GBS, because someone else said that it is for glucose actually with the gestational diabetes, that does not really have that much to do with strep. So group beta strep is a naturally occurring bacteria that a lot of women have. But then what happens is if someone does have group beta strep and it passes on to their baby during delivery, it can cause infection. So that's why it's very important to know your GBS status. Now for labor and delivery, I'm trying to think of a question. What is one thing that must be done, hopefully, in that golden hour? So what is one thing that you want to happen during that golden hour? We talked about a few different things. That's the first hour of life, exactly. So you want skin to skin time, you want to initiate your breastfeeding, you want to be able to start your connection between mom and baby. And then we did talk about signs of labor. So what is the difference between true and false labor? So we talked about different signs of true labor, different signs of false labor. If you were at home and starting to contract, how do you know if this is true labor and how do you know if this is false labor? And we did talk about a few different things. Now we'll give you guys a minute. Exactly. Irregular is false, and then regular and consistent is true. And then usually regular does not go away with rest and drinking, while false labor does go away with drinking water. And then exactly, well, Mary, greater than 6 contractions in an hour, just because you have a lot of contractions does not necessarily mean that you are in true labor, because you can still have small contractions frequently, inconsistently, and that can be false labor still. Greater than 6 contractions an hour can mean that you are starting to be there. Exactly, because they can still be frequent but inconsistent. So they have to be inconsistent, false, consistent is true. But that was a very good realization, though. A very good answer. So all of you guys had very amazing answers for everything. So the people that were involved with our review are now entered for the giveaway. So what I'm going to do is everybody can say a number between 1 to 10. I'm going to do it very, very easy. So do a number 1 to 10, you can type it down, and then when everybody has had their number, I'm going to say who won. All right. And then I think that's everybody, right? 1, 2, 3, 4. Yeah, I think everybody has said. All right. So actually, Mary has won this giveaway. Mary Catherine has won my giveaway for the free consultation. So what you can do is on mommydidyouknow.com and then click the consultation. So I wrote it on there too. So under mommydidyouknow.com, you're very, very welcome. Click the consultations tab, and then you'll be able to sign up. And then where it says, where did you hear about us? Just write giveaway winner, and then I'll remember your name. So you just under mommydidyouknow.com, and then I have a consultations tab there, super, super easy. You can sign up for electronic visit, and then we'll be able to make your arrangements from there. And then just put giveaway winner so that I'll know that your fee will be waived. And then of course, all of you guys will be able to sign up as well for consultations under that same. You just do mommydidyouknow.com. You click the consultations tab. So as we are finalizing this class, I would like to know from everybody what you guys thought of the class. What was your favorite thing that you learned? If you learned anything that was exciting, different things like that. I know for me, my favorite about this class is that it is a very interactive class, that we can answer questions and we can be more interactive. We can be more personal with it. Especially, I know that there's only so much that you can learn from videos. But quickly show your stages of labor slide again. Sure, let's see where that slide is. Okay, here's my stages of labor slide. So we have the early labor to full dilation, we have the pushing stage, delivery of the placenta, and the golden hour. I'm very happy that all of you guys have joined. I know that some of you also probably are joining from my notification on the website or something like that, but it was very, very nice to meet all of you. And at least you get to see a face to the voice from Mommy Did You Know? And I know that it's completely different when you get to see someone face to face. And you can also sign up for additional classes as well. Just because every class is a little different. This one was more of pregnancy and childbirth. We didn't really get into the postpartum and newborn care. With the next class, I'm going to get more into postpartum care and newborn care, which is on the Eventbrite page. You'll be able to sign up for additional classes. And these are free, so you can sign up for as many as you want. So I wish you guys all the best. And you can also see more videos on YouTube. I also have a really nice YouTube channel. You can always subscribe to it. I have lots of classes on there as well. But I wish you guys all the best. And I will be canceling out, stopping the video for now. But I wish you guys an amazing pregnancy. And I hope that you guys are blessed and have a wonderful rest of the day. Bye-bye, everyone.